Before I introduce our speakers and topic for today, I have some logistics to go through. This CME activity is jointly provided by the Queen's Medical Center and the UH Jabsom Department of Geriatric Medicine. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CMEs. You can find our evaluation form by following the link in the chat at the end of this presentation, or in our email advertisement, or on our website. CMEs are sent out by our sponsor every year in mid-January. Your comments are very important to the planning committee and will be used to plan future programs, so please be generous with your comments. All of our speakers today have no financial disclosures with commercial entities. So this is my favorite Grand Rounds of the year, the last one of this academic year. We always have this be our fellows, research and quality improvement and medical education projects. So today we are very happy. We have 5 fellows presenting as well as 1 medical student. I'll go ahead and do all the introductions right now. We'll have each of the projects be presented, and I'm going to ask everyone to hold your questions until the end. So we'll have all 4 presentations, and then we can ask questions of all of our speakers. So our first fellow is Dr. Kelly Kurosaki. She's a second-year fellow. She was born and raised on Kauai. She attended the Cadleck Family Medicine Residency Program in Washington State. She's extremely interested in primary care geriatrics, and after graduation, she's going to be joining the Kokini Primary Care Clinic. Our next fellow is Dr. Pedro Aguilar. He was born and raised in Guatemala City, completed CMAR Family Medicine Residency training in Washington State. He loves to be able to spend time with our kupuna and learn about them, their lives, and their families. That's what drew him to geriatrics. Next year, he will be a second-year fellow and will also be completing the Office of Medical Education Fellowship. Our next fellow is Dr. Kapono Chang. He's also local, born and raised in Kaneohe. He completed the UH Family Medicine Residency Program. And the reason he chose geriatrics is he enjoys helping kupuna and their families through difficult life events. After graduation, he's going to join the KKV clinic to do primary care as well as geriatrics. Next is Dr. Kiana Chuloy. She was also born and raised in Kaneohe. She completed her internal medicine residency at Kaiser in Hawaii. She loves geriatrics because it's challenging, complex, and rewarding all at the same time. After graduation, she will be joining HPH and be working in the outpatient geriatric clinic setting. Our last fellow is Dr. Jenny Davila. She grew up in Oceanside, California. She went to the CMAR Marysville Family Medicine Residency in Washington State. Her reason for joining geriatrics was she loves working in team environments. After graduation, she's going to be joining the post-acute and long-term care team at My Health. So I'm really happy to say all 4 of our graduating fellows are staying here in Hawaii. That's got to be a record, and we're really thrilled about that. Lastly, our medical student, Ayumi Sakamoto, also was born and raised in Hawaii. She's currently finishing her 3rd year of medical school at Jabsom. We're really lucky. She was interested in geriatrics and particularly in dementia care since the very beginning. She came to us from the very beginning. We got to know her in the very first week of medical school. And we're really hoping that a few years from now, she'll be presenting again as one of our graduating fellows. So please welcome all our speakers. I also want to give some acknowledgements out. This research, many of the projects today, 3 of the 4 projects that are being presented are based on data from the Kokini Honolulu Heart Program and Honolulu Asia Aging Study. So I just want to acknowledge the staff over many years. We've had some wonderful staff, and that's the reason why we have such exquisite, beautiful data for this study. I also want to thank Kokini administration. This study started in 1965. And so this is the 59th year of follow-up for the study. Now, most of the time we have had NIH funding, but there have been times when we have not. And through all of the difficult times, Kukini hung in there and supported the program, and they've been supporting the extensive biorepository for all of these decades. I do want to also shout out to the Kukini Honolulu Heart Program participants and their families for their dedicated service to this project. The study started out with 8,006 in 1965. We now have 4 of the original 8,006 still alive. The youngest is now 104 years old. So this is an amazing study of extreme old aging. I feel very honored to have worked with these men for many decades now. They are a really unusual group of men. They were part of many of them were part of the 442nd and the 100th Battalion, which is the most decorated unit in the history of the US military. So it's been a really honor for me to be able to work with them and their families. Okay, after that long introduction, let's start out with Dr. Pedro Aguilar. He's going to be presenting his research project. Take it away, Pedro.
Perfect. Thank you, Dr. Masaki. Can everyone hear me okay?
Yes.
Okay, perfect. Thank you. So for our project, we wanted to present our abstract, which was related to low midlife dietary protein intake as it relates and predicts higher all-cause mortality over our 5 decades. And like Dr. Masaki was mentioning, this data set comes from the Kuakini Honolulu Heart Program. So I do want to thank everyone whose hard work over 5 decades have led us to be able to dig into this data and find so many interesting things. So as Dr. Masaki mentioned, this project had some support from the Geriatrics Workforce Enhancement Program, but there's no financial disclosures. So as background, just would like to point out that the current recommended dietary allowance of dietary protein intake is measured in grams per kilograms of body weight, and it is 0.8. But studies have shown mixed results as it is related to all-cause mortality. So we used our data set from the Kuakini Honolulu Heart Program, as Dr. Masaki mentioned, was established in 1964 with the initial 8,006 patients selected. We wanted to study whether the midlife protein intake of these volunteers predicted mortality over 5 decades of follow-up. The baseline exams were conducted between 1965 and 1968, meaning the men were aged 45 years old to 68 years old at the time. And the data set that we actually used after excluding missing data was a total of 7,486 patients. And it was available to us through December 2022. Our initial protein intake was calculated from a 24-hour diet recall performed by a registered dietitian at the time. And we were able to identify sources of protein, dividing it between animal and plant protein. And then we calculated the total protein intake by kilogram of body weights. We then created quintiles of protein intake to be able to do some statistical analysis. So on to our results. You can see that these are the quintiles of average protein intake expressed in grams of protein per kilogram of body weight. You can see that the first quintile is the lowest protein intake, and the mean of that quintile is right at 0.83 grams per kilogram, so right at the recommended dietary allowance. And then the highest protein quintile had an average of 2.38 grams per kilogram. And then at the bottom table, you can see how we split the from source of protein intake, whether it was vegetable or animal protein intake. So there was a higher animal protein intake compared to vegetable. These are the Kaplan-Meier curves for the quintiles, and you can see that number 1, which is I know it's hard to see the colors on the graph here, but the sorry, the blue is the lowest protile, the lowest quintile. And so sorry. On here, kind of expressed differently, is the age-adjusted mortality rate for quintiles of protein, and you can see how the lowest quintile, number 1, had the highest age-adjusted mortality rate of 39.7. And then there was a trend to decrease adjusted mortality rate for the higher quintiles. And this was a similar pattern across the different sources of animal protein intake. So after adjusting for certain risk factors, which was age, years of education, cardiovascular risk factors, and prevalent comorbidities such as coronary heart disease, stroke, and cancer, we compared the lowest protein, the highest protein quintile with the different quintiles. And you can see that there is a statistically significant risk ratio for the lowest protein intake compared to the highest. And this again was similar to the other sources of protein intake. Conclude, we did find that low midlife dietary protein intake was a significant independent predictor of all-cause mortality over our 5 decades of follow-up. And both low plant and low animal protein intake were associated with increased mortality. Thank you. I think we'll saving the questions for the end of the presentations, but I'm happy to answer any.
Thank you, Pedro. So we're going to save all the questions for the end. So please think about your questions, and you can even put them in the chat if you like. Our next presenter is going to be Ayumi Sakamoto, our 4th-year medical student. She's currently not feeling well and has actually lost her voice, but fortunately she presented her abstract at the American Geriatric Society National Conference, and we have the video recording from that conference. So we're going to be playing the video recording. Thank you, John.
Hello, my name is Ayumi Sakamoto, and I am a 3rd-year medical student at the University of Hawaii John A. Burns School of Medicine. Today, I'd like to present my project on the FOXO3 genotype and its role in mitigating the effects of low bioavailable testosterone on total mortality. Before I begin, I'd like to thank my mentor, Dr. Kamal Masaki, and all of our wonderful co-authors for all their support with this project. These are my disclosures. So to give some background, we were interested in pursuing this project because other studies in the past have shown that age-related decreases in testosterone is associated with a greater risk of total mortality. However, there are very few studies with a long follow-up period, and even fewer studies that have examined this association in Asian and Asian American populations. Therefore, we wanted to see if these findings could be applied to our cohort of Japanese American men with a 32-year follow-up period. We were also curious to see if the FOXO3 gene had a role in our story. So for context, FOXO3 is a gene that has been associated with longevity in multiple studies. It's thought to play a major role in mechanisms such as homeostasis, cell cycle regulation, and metabolism. So to talk a little bit more about this FOXO3 gene, the first report that identified the association between 3 FOXO3 SNPs and longevity was actually produced by researchers at the Kuakini Medical Center here in Hawaii. So what they found was that individuals who had at least one copy of the minor G allele of SNP RS2802292 of the FOXO3 gene had a significantly longer lifespan than those who are homozygous for the major T allele. There's also growing evidence that FOXO3 may be a so-called resilience gene that can mitigate the harmful effects of certain disease states. So for example, one study showed that men with cardiometabolic disease had decreased mortality risk if they had the FOXO3 G allele. Another study showed that subjects with hypertension had a decreased incidence of consequent coronary heart disease, intracerebral hemorrhage, microinfarcts, and even dementia compared to their peers who did not have a copy of the FOXO3 G allele. So altogether, our objective was to study the association between bioavailable testosterone and total mortality in our unique cohort with long follow-up period, and also to look to see if there was an interaction with the FOXO3 genotype. So for our methods, our data is derived from the Kwikini Honolulu Heart Program, which is a population-based cohort of 8,006 Japanese American men who have been followed since 1965 here in Hawaii. And of this original cohort, the serum hormone levels of 3,741 men were measured between 1991 and 1993, which is when the subjects were between 71 to 93 years old. We then excluded 603 subjects due to missing data, which left us with our final sample of 3,138 men that we followed through the end of 2022. Our primary outcome is total mortality over 32 years of follow-up. So for our predictor variable, we used bioavailable testosterone, which we divided into quintiles. We also looked at our baseline covariates, which I've listed here, and this includes age, FOXO3 genotype, risk factors for cardiovascular disease, such as BMI, serum cholesterol, 5 years of smoking, physical activity, alcohol use, and hypertension. We also looked at the prevalence of cardiovascular disease, such as diabetes, coronary heart disease, stroke, and also the prevalence of diabetes, of dementia and cancer. So for our statistical analysis, we use general linear models to look at baseline variables across quintiles of bioavailable testosterone. We also looked at age-adjusted rates of all-cause mortality and Kaplan-Meier survival curves to look at the relationship between all-cause mortality and bioavailable testosterone level. And finally, we used multivariate Cox regression to look at relative risk across quintiles and also looked at the interaction between bioavailable testosterone and FOXO3 genotype. So first, we have our baseline variables by quintiles. So Q1 represents the group with the lowest bioavailable testosterone and Q5 the highest. So as you can see here, there are significant differences in age, diabetes and cancer prevalence, BMI, and cholesterol levels across our quintiles. Subjects in the higher quintiles tended to be younger, had lower BMI, and lower prevalence of diabetes and cancer. But interestingly, serum cholesterol levels tended to also be higher in those in the higher quintiles. And of note, there were no significant differences in the other baseline characteristics listed below, which it also includes the FOXO3 G allele prevalence. This is our Kaplan-Meier survival curve, which demonstrates decreased survival in Q1, the lowest quintile, as represented by the blue line. This is our age-adjusted mortality rates per 1,000 person-years of follow-up, which solidifies the association between low bioavailable testosterone and increased incidence of all-cause mortality. In our multivariate Cox regression, we use the highest quintile Q5 as a reference and adjusted for all covariates mentioned previously, including FOXO3 here. So what we found is that there was a 20% increase in all-cause mortality in the lowest quintile when compared to the highest, Q5. We also noted that there are no significant increases in relative risk for mortality in quintiles 2, 3, and 4 when compared to Q5. We then repeated our multivariate Cox regression by FOXO3 genotype status, adjusting for the same parameters except for FOXO3. So when we looked at the Cox regression in the group who did not have any copies of the FOXO3 G allele, meaning that they're homozygous for the T allele, we saw that there was a 34% increase in all-cause mortality when we looked at Q1 versus Q5. We also noticed that Q2, Q3, and Q4 all also had a significantly increased risk of all-cause mortality when compared to Q5, which is not what we observed in our previous Cox regression, where we had adjusted for FOXO3. But what was really interesting is that when we looked at the FOXO3 G group, we saw that there were no significant differences in any of the comparisons, even when comparing Q1 to Q5 and adjusting for all of the same covariates as before. So some of the strengths of our project was that this is a population-based study design. We had a relatively large and unique cohort with a very extensive follow-up period. We also had a complete surveillance for mortality and the advantage of having FOXO3 data available to us. However, some of the limitations of our study was that we cannot really generalize our findings due to having a rather homogeneous and unique cohort. We also only had sex hormones measured at one point in time, which limits our ability to evaluate the rate of change of our age-related hormone decline. And finally, this is an observational study, which innately limits our ability to understand cause and effect. So in conclusion, our data supports the finding that low bioavailable testosterone is associated with increased risk of all-cause mortality in our cohort of Japanese American men that are followed for 32 years. We were able to see a 20% increase in total mortality when comparing Q1 to Q5, even after adjusting for FOXO3 genotype. We're also able to report a significant interaction between bioavailable testosterone and FOXO3 genotype, which to our knowledge has not been investigated before. We found that the proposed negative effects of low bioavailable testosterone on lifespan were pronounced in individuals that were homozygous for the major T allele. And in this group, we observed up to a 34% increase in total mortality risk when comparing Q1 to Q5. And the highlight of our study was finding that this proposed detrimental effect of low bioavailable testosterone on lifespan was somehow mitigated in men who had the copy of the FOXO3G allele. And this suggests that there may be a potentially protective role of FOXO3G in the context of low bioavailable testosterone. So for future studies, it would be really interesting and important to see if similar results can be replicated in other ethnic groups, and also to maybe see if there can be parallel studies that can be done in female cohorts as well. These are my references. Thank you very much for listening, and I would be happy to answer any questions at this time. Thank you again.
Thank you, Ayumi. We'll go on to the third presentation, which is going to be shared by two of our fellows, Dr. Kapono Chang and Dr. Kiana Chuloy.
Hi, everyone. I'm Kapono, one of the first-year fellows, going to be presenting with Kiana, also one of the first-year fellows. So I'll be doing the first half. So this project was the annual Queens Department of Geriatrics QI project that the fellows, that me and the other fellows were involved with this past year. And, as we know, it's difficult to kind of come up with a project where all providers can participate meaningfully. And in the Queens Geriatric Department, there is the inpatient group, the outpatient geriatric clinic, the home-based primary care, and the post-acute and long-term care group. And what's similar across all groups is medications. And especially in our geriatric population is polypharmacy and these potentially inappropriate medications, or what we call as PIMS. So in discussion of preparing this project, the mission of the department was to see if we can, one, identify patients with these potentially inappropriate medications, and with a kind of geriatric background and managing these patients, are we able to decrease it or taper them down in a safe way? So, yep, also in conjunction using Beer's criteria. And as we know, risk of polypharmacy, adverse effects, drug-drug interaction, especially in our geriatric population, risk of falls, disability, placement, non-adherence, and then especially financial burden, looking at quality of life, and most importantly, making sure we are not contributing to increasing mortality. The next slide. So again, as I reiterated, developing a project where all 4 service lines are able to participate and carry out a project and a meaningful impact in patient care and things that we can improve in quality. So like I said, the inpatient, post-acute, long-term care, outpatient, and home-based primary care.
All right, so in terms of methods, our research project involved having a geriatric physician as well as our nurse practitioner team members identifying patients with polypharmacy. And all of these patients have not seen a geriatrician in the past 12 months. And then another important exclusion criteria was they could not be enrolled in hospice. So in terms of the pre-intervention data, we obtained total number of medications, names, drug categories, high-risk medications, so any meds that were part of the Beers list. We also looked at dosing and frequency. And then for the intervention, it entailed a geriatrician or the nurse practitioner provider making recommendations for dose reduction, tapering, or discontinuation. And this was after a complete assessment of the patient. And then for post-intervention, all the same data was obtained that was done in the pre-intervention data. And this was collected at different timeframes just due to the nature of the different care settings. So for hospital patients, it was 1 month or at discharge. For SNF patients, it was 3 weeks or at discharge. And then for our clinic or home-based primary care patients, it was at 3 months or at death. So let's go over the results. So this chart here shows the percent of patients with changes in medication numbers before and after intervention. And you can see here the green represents patients who had a decrease in medications. The yellow is no change or the same, and red is an increase in medications. So for the 2 categories for routine meds and total meds, we saw about a 60% of patients with a decrease in medication number. And then for our PRN meds and Beers meds categories, we saw respective 36% and 46% of patients with decrease. And then you can see very little or very small percentage of patients had an increase in medications for all the different category types. And that's represented in the red bars, red colored bars.
And Kiana, if I can add that
Yeah.
that 5%, we couldn't quite break it down into the 4 service lines. So majority of those increases, are necessary, like in the inpatient setting, if they're requiring narcotics. So that definitely we couldn't really separate that out in these graphs.
Yes, thank you. So this is the second graph. This one shows the mean number of medications per patient before and after intervention. And so you can see here all the same data categories as the last graph. And the biggest thing to point out here was there was a statistically significant decrease, as you can see with all those p-values for all the different categories. And just to point out the total meds, we saw a reduction from 12.53 to 10.77. And then more importantly, in the Beers meds group, you can see a very highly statistically significant reduction from 2.28 to 1.47. So you can see with that p-value. So in conclusion, we saw significant deprescribing patterns across all the 4 different care settings, particularly in our high-risk Beers meds. And then we also saw trends in reduction for all high-risk medication classes, which I wasn't able to show you due to time, but we did look at all the different medication classes, and we were able to determine that opioids were the most commonly prescribed from the Beers criteria medication list. In terms of future directions, I will say this was data from our preliminary data for the abstract. And so this included 60 patients from 20 different providers. However, the total data will include about 112 patients. So we do want to look at that data as well. And then we can hopefully use that to see what kind of support we can provide for the different service lines in terms of deprescribing, and also look at educational interventions from this data that we can learn from in terms of helping to support all of our primary care physicians. So yeah, thank you so much. All right.
Thank you, Kiana and Kapono. Last presentation will be by Dr. Kelly Kurosaki, a second-year fellow.
All right. So my project is on mortality in Japanese American men with loneliness and depressive symptoms. My project was also part of the Honolulu Heart Program. The research was supported by the Department of Geriatric Medicine at JAPSON and the University of Hawaii, also supported by Kuakini Medical Center and the National Institute on Aging. I also wanted to say a little special thank you to everyone who has helped with the Honolulu Heart Project, and for Dr. Masaki, who has met with me so patiently and explained everything step by step. Also, Randy Chen has also been great with all the statistical analyses and making figures for this project. So there's been a lot of discussion on loneliness in the past several years. Loneliness is described as the distressing emotional experience that's a result of perceived unmet social needs. It's been associated with ADL decline, frailty, depressive symptoms, dementia, heart disease, stroke, and all-cause mortality. In 2002, the 43.2% of adults who were older than 60 reported feeling lonely, and 13% were lonely often. In May 2023, the US Surgeon General actually declared loneliness and isolation as an epidemic in the United States. The University of Michigan National Poll on Healthy Aging has kind of trying to track loneliness in adults. So they actually had data from before the pandemic. There was 27% back in October 2018, and then they saw a peak in 2020, right when we were in the height of lockdown, where 56% of adults 50 to 80 years old felt lonely or socially isolated. And it's slowly been coming down. Back in January 2023, about 34% reported feeling lonely. And then we also looked at depression, depressive symptoms, because depression has been associated with increased risk of stroke, heart disease, dementia, mortality. In 2021, about a third of older adults reported depressive symptoms. And most studies, they've been looking at the association of loneliness or depression with mortality, not both. So the objective of our project was to look at the effect of loneliness and depressive symptoms in late life on all-cause mortality in our older Japanese American men in Hawaii. So we also used the Kuakini Heart Program, the population-based longitudinal cohort study, where they enlisted men aged 45 to 68 years old when the study started in 1965 to 68. Our data came from exam 4, which was conducted in 1991 to 1993. We started off with 3,741, 71 to 93 years old. We excluded people who were living in care homes, nursing homes, and rehab facilities. We also excluded participants who lacked the valid depression screen or the valid loneliness question, and we ended up with a final group of 3,186 participants. We had two main predictor values. So we looked at depressive symptoms based on the Center for Epidemiological Studies Depression 11-item scale. It was about feelings and behaviors in the past week. If they scored at least 9, that was clinically significant, and they were considered to have depressive symptoms. And then for the loneliness, this was based on a single item on the CESD-11 saying that I did feel lonely in the past week. We also did this 4-level predictor value variable based on the presence and absence of loneliness or depressive symptoms. So, for example, the first part was they had neither depressive symptoms nor loneliness, or in the other group, they had depressive symptoms only, or they only had lonely symptoms, or both were present. The outcome variable we looked at was all-cause mortality. So we had this comprehensive surveillance system based on records from hospital discharges, obituaries, death certificates, medical examiner's office. And we had a mortality data available through December 2023, giving us up to 32 years of follow-up. Our covariates included age, cardiovascular disease risk factors, such as BMI, physical activity index, cholesterol, hypertension, smoking, diabetes. We also looked at the presence of chronic diseases, functional impairment, and cognitive impairment. We're also looking at social factors, so if they weren't married or if they lived alone or they had no help. The analyses we all did separately based on the following predictors, so whether or not depressive symptoms were present or absent, same thing with loneliness, and then also with that 4-level variable that I talked about earlier. And then we looked at the age-adjusted mortality rates, the Kaplan-Meier survival curve, and the multivariate Cox regression to calculate the relative risk for mortality. So for our results, over 80% of participants had neither depressive symptoms or reported feeling lonely. 169, so a little over 5%, reported both depressive symptoms and feeling lonely. And then we kind of had about the same, like 4 to 6% who either had depressive symptoms only or they only felt lonely, but not depressed. These are our age-adjusted mortality rates. So on the y-axis, you can see the per 1,000 years of follow-up, and then on the x-axis is our 4-level variable. And as you can see that we have a significant increase in the age-adjusted mortality rates, especially once we add the presence of loneliness. And then this is the Kaplan-Meier survival curve. So on the y-axis, we have the survival rate, and then for the x-axis, the years of follow-up. And the red line is the participants who are neither lonely nor depressed. And then you can see kind of like the other curves, whether they were only lonely, only depressed, or had both, there's a significant difference in their Kaplan-Meier survival rate. And then in the Cox regression models, we kind of saw a similar thing. So once we adjusted for all of our covariates, we did see a significant increase in the relative risk once we had people who were lonely. So if they were lonely or they were lonely with depressive symptoms, then we did see a significant increase in the relative risk. So there's a couple theories about why this happens, and the best one I could find for the loneliness association with all-cause mortality was based on this loneliness model, where lonely individuals felt unsafe and were hypervigilant for additional social threats in the environment. So this would diminish self-regulation and would kind of lead to increased stress, poor health behaviors such as smoking and affecting the restorative processes such as sleep. And then, as we all kind of know, like a lot of that would lead to adverse health conditions such as diabetes and cardiovascular disease. And then depression also kind of followed a similar idea where we had the poor health behaviors from the depressive symptoms, which are the primary contributor to the increased risk of cardiovascular disease. Strengths of this study include that we had a really long follow-up of up to 32 years. We also had a pretty large sample size with minimal loss to follow-up. It was a population-based study with nearly complete surveillance data in a unique population of Japanese American men. And it's also one of the few studies of both depressive symptoms and loneliness. Limitations, well, it's pretty limited generalizability because we only had older Japanese American males. It was also an observational study, so we can't assume causality. Loneliness was also only assessed by a single question at one point in time, and depressive symptoms were also assessed only at this single point in time. Our conclusion is that loneliness, both by itself and in the presence of depressive symptoms, was a significant independent risk factor for all-cause mortality in Japanese American men in Hawaii. And having both loneliness and depressive symptoms together had the worst outcome. Future directions might include other longitudinal cohort studies in different ethnic groups, age groups, and in women, and possibly looking at interventions to reduce loneliness. And that's my project.
Thank you, Kelly. Thank you, Kelly, and thank you to all our presenters for wonderful presentations today. All of you did a great job. Let's open it up for questions now. I see one from Warren. Warren, do you want to unmute yourself and ask your question?
Sure. They're not in relationship specifically to any of the presentations, but I just, Kamal, this, you might be able to answer this as well as anybody else's. Has the aging study looked at biomarkers of chronic inflammation, also issues such as sleep patterns or social determinants, which are, the hot topics these days?
Yeah, so yes, we do have some markers of chronic inflammation. For example, we have C-reactive protein, but only in a subset of the population. So it was done like as a case control. So we don't have C-reactive protein on everybody, but we do have it on some. We have other markers of chronic inflammation. I think we have serum fibrinogen on everybody at exam 4. We have WBC counts on everybody at exam 4. So those have been looked at with various different outcomes and have been found to be good predictors. Sleep, we have sleep history at all the old age exams, but we actually have polysomnography done at exam 7 on a little over 700 people. For that, we've looked a lot at cognitive outcomes, but not as much with mortality. So that's definitely an untapped area. And then, yes, we do have a lot of things on social networks and social determinants of health as well. Hope that answers your question, Warren.
Thank you.
Okay. Pedro, we have a question for you from Dr. Wishick. Gabriel, would you like to unmute yourself and ask the question?
Sure, yeah. Hi, Pedro. Thank you so much for that. Some of that went by too quickly for me to be sure that I got this right, but I was just wondering, it looked like there might have been an elevated risk ratio for mortality for the group that was eating plant protein. And I was just curious about that, if I'm right about that, and if so, why? Because usually we think of vegetarians as living longer.
Yeah, excellent question. Yeah, I think we saw a similar pattern in both the animal and plant protein intake, which was like the total amount of protein intake that they were having. If there was less than the recommended dietary amount, that it was associated with increased mortality. I think like the main concern with vegetarian diets, apart from like the micronutritional deficiencies that could arise from there, is like the amount of vegetables you have to take to be able to increase your total amount of protein. It just has to be a lot more voluminous, right? But we didn't kind of explore that in more detail with our subset of patients, but because both of our patients were, we didn't have patients who, or were not able to analyze patients who were only on a vegetarian diet per se. Patients were both at getting meat, vegetable and animal derived protein diets, but for both lines, I guess, like the less protein meant higher mortality.
Yeah, and this may not have been, sorry, go ahead.
You do bring up a good point. We expected to see that low plant protein would be higher mortality, but not necessarily the same for animal protein. But we found that both went in the same direction. Go ahead, Gabriel, you had another question?
Oh, no, I was just going to say for Pedro that I think I can imagine, although I have no knowledge of the research on this, I can imagine that a lifetime healthy vegetarian diet is cardioprotective and lots of other things, but perhaps into the older years, there's some differences in what people need to maintain muscle mass and such. So, you know, very interesting. Thank you. And then Kelly, thank you so much. My question for you is about the survival curves. The depressed group went down very quickly with everybody else that was on the lower side, but it seemed like at 15 years, there was like, that was the only group that jumped back to where the neither group was with a better survival. And so I was just curious if people are getting some euphoria or happier as they age into their later years or something, if we have any idea why that might be.
I honestly don't know. I feel like that's a really good question. We wouldn't be able to tell from what the data that we have because we only looked at those depressive symptoms at that one point in time. But I think I came across a paper at some point where they kind of looked at something kind of similar. So if they didn't get depressed again, then it didn't, their kind of like mortality risk, I think, returned more to normal, like as if they hadn't been depressed. But if they did get depressed again, then I think it kind of impacted their mortality rate again. But it's been a while since I looked at that paper.
We do have depressive symptoms at multiple points in time, but not at every exam cycle. So for example, we had it at exam 4, and then we have another one at exam 7, which was 10 years later, but we don't have it at every single exam cycle. But there is a possibility of looking at that, change in depressive symptoms. So thank you. Are there any other questions for our fellows or for Ayumi? No questions? Comments, questions, anyone? Give it another minute. In the meantime, Michaela or Justin, if you could add the evaluation link into the chat, that would be wonderful. Great, thank you, John. If there are no other questions, we'll end a little early. I again wanted to thank our fellows and medical students for their wonderful presentations and for doing such a great job with their research and quality projects. These, they make this seem really easy with these short 10, 15-minute presentations, but I can tell you it's many, many hours of very hard work. So we truly do appreciate them for their hard work and are really happy to celebrate all their accomplishments in this last grand rounds of the year. If there's nothing else, we'll see you all next month in July for our next academic year. Okay, thanks everyone. Bye.
Thank you.